Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
Welcome to the THOR Table of Knowledge podcast. I'm here today with Gareth Strandinus, who's been a co-director of the THOR network with myself for the past 14 years. And I thought we'd talk about emergency preparedness and your role in Norway with really with designing and implementing the emergency preparedness plan in Norway. So where are you now?
We can really start how this started as a kind of a military-civilian cooperation project. It's really started back in 2009 when we were on a deployment in the Gulf of Aden with a surgical team on board and the Naval Special Operations Command on board. And we decided that the only way to provide blood on a surgical team on a frigate in the Gulf of Aden was to use a walking blood bank and use the personnel on board as donors.
Right.
Then I got back. I became the senior medical officer of the Special Forces, Naval Special Forces in Norway, and realized that these guys need something else than saline. So we immediately contacted the chief of the blood bank and said we need a walking blood bank program so we can make blood available for these guys wherever they are, especially in the austere environment. So that kind of triggered the kind of contact I had with you. I read all your papers and we got in contact, met in the bar, you remember?
Limerick Bills.
And so it all started, and that was
With the Guinness.
With the Guinness. It started with the Guinness.
That's cool.
Cheers.
Cool.
So this has the kind of make a long story short. Now we have developed this walking blood bank program that's kind of a military concept used since World War I into the civilian preparedness planning.
Right.
So we had a very robust blood preparedness program during the Cold War. Now we had peacetime for so long, so this preparedness plan was just put in a drawer and it just got away. So we now have to rebuild it.
Right. So for the audience that doesn't know what a walking blood bank means, can you just kind of describe? I'm not familiar.
Yes. So blood is a freshgorfy, so you cannot keep it for that long in the fridge. So instead of keeping the blood in the fridge, you recruit donors that are fulfilling the same criteria as any blood donors in a blood that requires in a blood bank. So same criteria for them, but they are readily available to donate blood in emergencies when you need blood, especially in places where you are unable to store blood, even because of the geography of the way they are, or in hospitals that has a limited availability of blood products. Then you can call in donors, and we use Group O. We call it universal donors or emergency donors, whatever you want to name it. That is a low titer of donors that can show up on the donation site, wherever that donation site is. That could be in our university hospital. We have this preparedness for the second largest trauma hospital in Norway. We have our preparedness plan using regular donors. We call them in with a special system. If we, like say, we run out of platelets, we cannot just call another hospital to have fluid platelets because then the patient will have blood death in real time. So then we need an emergency planning, and that's the walking blood bank plan. And we can use that kind of plan in remote areas, in local communities, fishing communities. So we now have decided.
Right.
Yeah.
So if I understand you correctly, a walking blood bank is basically the immediate collection of whole blood from donors, and then the immediate utilization and its rehabilitation.
Yeah. So it's immediate transfusion to the, so you just draw it and transfuse it, meaning you're giving untested blood.
Right. So since it's untested and there is a small chance of a transfusion transmitted disease, I would think that could be as serious as HIV or hepatitis. How did you get the blood community in Norway to accept this approach because, as we understand it, there's no other civilian use of a walking blood bank in the world that's been established and used.
Yeah,
How do you change practice?
is a kind of a convincing process into the blood bank community to make them understand the risk-benefit analysis on the scenario array. So the chances of kind of the mortality of patient in hemorrhagic shock, wherever they are, in the pre-hospital arena, is somewhere in the ballpark of 25 to 40%. So I mean, the chances of dying in 1 to 3. Using regular donors in Norway has a zero conversion rate of 1 per 100,000 donation per year. Meaning this is the chance of dying of 1 to 3 and the chances of getting a virus infection that you can survive the rest of your life with for 1 to 100,000 or something like that. But we recruit the donors that are kind of the same criteria as the regular blood bank use. So we do test them every 6 months.
Yeah.
We virus test them every 6 months, and we educate them to tell them if you have done something that might be a risk of acquiring getting a virus disease that make you unable to be blood donor, you should tell. So you should just don't show up. Right? When we call you for donation, you should just don't show up because it's volunteer, it's non-paid. But they sign a paper that they are willing to, on any time of day, any time of year, middle of the night, willing to kind of step up we call them emergency donors. So in the austere environment here, the distance from where they live to the blood bank is so long that it's too long for them to be regular donors. Like up in the north, there's a huge area, long distances. So they normally are not regular donors. They are what we call an emergency donor, fulfilling the same criteria as the regulatory approval requires for being a donor.
Right. So it may sound like, drawing blood from a donor, putting it in a bag, and then giving it to a patient is pretty simple and wouldn't need a lot of training and education. But it is a little more complicated than that. So tell me about your training and education program for the people implementing.
Sure.
Walking.
That requires a lot of effort and training. So we have developed this course. We actually use the online course that the THOR network has developed. So that's kind of everyone who is participating in that course. So in these local communities, we have physicians, nurses, even dentists, ambulance drivers. So it's fairly easy. We have proven it's fairly easy to kind of educate what we call a phlebotomist, one who is able to draw a unit of blood. So we have this 2-day course, and then we have all this documentation they need, all the protocols and all. Yes, they have videos that they can go in and see that for themselves, and they do regular training. So we come back and help them out with because the systems is not the same. In one local community, they may have a little different system than the other one. So they kind of adapt their program to their system, so it fits their system. So this is a logistical procedure. So, making a blood bag available is a logistical procedure. You have a system for how do you call in donors, and then we have a very short interview because we don't have time to do the regular interview because that's take time. So we take an interview. We have 5 very simple questions we ask them, and if they ask correctly on all the 5 questions, they are kind of, and then we have someone who is educated to only draw the unit. So they train to draw units. So when we are not there, they have at least every 3rd month they train the system, and then when they feel comfortable with the building the system, the logistics they need in their community, we have actually not ourselves. We have trainers. So we have someone externally coming up and actually say what do you call it? Approve. It's kind of an approval process.
Okay.
Blood bankers from another region actually come up and see how they do it, that they actually fulfill the criteria for doing everything correctly. I'm in charge of kind of the clinical part of this. So when we exercise, I kind of give inputs on clinical, because teaching them, the most difficult thing to teach it, because these are general practitioners that normally don't see very injured patients. So they have some bleeding patients now and then, but to teach them when, right, a patient need a transfusion is kind of a challenge. But I think we've been able to make a good system. So we now have so far 9. So they push the button on any kind of, if an ambulance driver call in to the healthcare center, see we have this very sick patient who's pale, his history is that probably is bleeding somewhere. We immediately trigger the walking blood bank. So we just start collecting the donors coming into the healthcare center, which are drawing the blood. And then the clinician, the physician then makes the decision.
Interesting. So I was going to ask, is there some type of public health authority that has to approve the use of the walking blood? It's more than just the physician.
No, it's the public health authority. So we have kind of the health department.
Okay.
And as that, so yes, it's kind of, we have approval on top to do this. So
how many times has this been done?
it's been done 9 times so far since we started in 2022, 23. Majority of the patient has been GI bleeds.
Interesting, right? Instead of trauma,
Instead of trauma.
It's
been a couple of traumas, but the majority is GI bleed or medical bleed.
Gotcha.
So we have one ruptured AAA in shock, and then we actually had one nosebleed as well. That was cancer in the nose operated, and you can really bleed a lot from the nose. So I mean, it doesn't matter where the bleed. It's like if they have a history of pride, because the history and the clinical expression of the patient is the decision-making process that the physician has to make, give or not. Several times we have triggered the walking blood bank and not give it.
Right. Well, that's good too.
So at least 3 of these triggerings has actually ended up with not giving the blood.
Right. Well, I mean, it's good in the fact that people are reassessing after initiating, and if they realize this bleeding has stopped, they've had
This is the experience from Don't Raise Afghanistan, that the biggest problem is they triggered the walking blood bank too late.
Understood.
So that is why we say that it's better to trigger it one time too much than the day you don't do it and you need it. It takes time. Okay.
So you're describing a lot of single patients that have exhausted the inventory of the local blood supply, if there's any there at all, and then using the walking blood bank. But what about mass casualty events?
Yeah,
and how you have prepared for those?
We have had exercises with that up in the north. So this is how we think it's going to work, because we have different civilian local community walking blood banks. And then we exercise kind of a mass casualty in one of these areas. So then there's helicopters coming in. We notify the hospital it's going to receive the patient, but then we trigger the walking blood bank in the other communities that actually are able to kind of transport the blood to the sea. And it's actually like the local community can actually we can ship blood from these different small communities to the hospital.
How fast?
Depending on weather, flight conditions. So there's a long driving condition, but I mean,
do you start collecting some whole blood though on scene at where the MCEs occur?
No. So the collection sites are the kind of the healthcare center isn't. We have picked the collection sites. So in the healthcare center we have defined collection site and where the patient is treated. So that's kind of separate. Okay. You kind of have the donor in the same room as the patient.
No, but if there's an MCE event in Bergen, right?
MCE in Bergen, then there will be the emergency services, helicopter services, either use a car or helicopter. They have blood on board, but they can also land in a hospital and get resupply from blood to the mass casualty center. And then the hospital will kind of trigger the walking blood bank to
right, in Bergen. That's what I meant.
Yeah.
Locally, you're going to start to collect blood.
Yeah.
But then you're going to get resupplied or additional blood from regional.
And we have that plan. Yeah. And we have triggered that plan like at least 6 times for single patient depleting our platelet inventory. So instead of waiting for platelets coming from Stavanger or Oslo, we do it much, much quicker by calling in regular donors, draw the units we need.
Yeah, great. Well, what you've done is phenomenal. It's really the only program in the world that I'm aware of that's using it for civilians. and the program you've built is very impressive. So thanks for what you've done. And actually, you've taught the rest of the world how to do it. So now our job is to export it.
We have a lot to do, fellas.
So guess what we do.
Cheers.
Well, thank you for that. And skål.
Skål.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.